Hello, and welcome to our webinar on ketamine treatment for mental health conditions, especially depression. We're so glad you've taken the time to join us live or via recording. I'm Kara Gavin with the Michigan Medicine Department of Communication, and this event is brought to you by the Michigan Medicine Department of Psychiatry. We know that ketamine has been in the headlines and talked about on social media a lot in recent years. It's available from clinics like the one here at University of Michigan Health, but you may also see private telehealth providers advertising ketamine therapy online or other clinics. We're here to help you understand what this treatment is all about, what we know about the effects it can have, and some of the safety considerations that it's important to consider. We're hearing today from three University of Michigan experts who provide ketamine therapy and have done research on it as well. And we're so fortunate to also have two individuals who have agreed to share their own experiences with ketamine therapy. I'll introduce those two in just a moment to kick off the event. First, our three faculty experts. Dr. Sagar Parikh is the John F. Graydon Professor of Depression and Clinical Neuroscience in the Department of Psychiatry of the Medical School. He's also a professor in our School of Public Health. He oversees our ketamine clinic, and he led the BioK study that evaluated ketamine's impacts on patients treated at 4 sites across the nation. Dr. Rachel Pasilio is a clinical assistant professor of psychiatry and the primary psychiatrist in our resident clinic, and her research focuses on safety related to ketamine therapy. And Dr. J. Marie Geller is the chief resident in our Department of Psychiatry and a fellow in child and adolescent psychiatry. She's doing research on psychotherapy and ketamine and can also address the potential for ketamine in younger people. Each of them will give a brief presentation, and if you're watching us live, you can submit questions at any time, and we'll pick some of them to answer toward the end. We know that there may be many questions, and we'll likely combine some of them on the same topic. Just know that our experts cannot give specific advice for an individual situation that you might be facing or someone you know. And if you can't stay for the whole chat or you want to share the recording with a friend, you'll be able to watch after the webinar ends through the Michigan Medicine YouTube channel. First, let's set the stage with a few words from the two people with lived experience of ketamine therapy. We're using their first names only at their request. Michelle is a ketamine infusion therapy patient at U of M, and she's very proud of her mental health journey and excited to share her story with others who might find it helpful, and believes that sharing her story, if it helps just one other person, it's worthwhile. So she's passionate about educating people on ketamine infusion therapy because she knows it can be the difference between someone living a full life or just surviving. And Linda, who will speak after her, is a patient who travels to U of M quite a distance to get her ketamine therapy and has found it very beneficial. And she tried other treatment options in the past, and she'll share more about that. We're grateful that she's joining us to share more about her journey, and she also hopes that sharing her experiences will help others. So, Michelle, could you tell us briefly about your journey before you started receiving ketamine?
Yeah, absolutely. So I've struggled with depression and anxiety for most of my adult life. I have also been in therapy since my early 20s, and um, it was keeping my symptoms at bay. It was allowing me to function. But as I ramped up to my 40th birthday, I got sick of just like you said, surviving, and I was looking for more. I knew that I was living such a small version of life, and there was so much more that I wanted to take advantage of, and my depression and anxiety were holding me back from that. So that's how I found my way to U of M, and I'm so thankful for Dr. Parikh and his work and the other researchers because ketamine has meant the difference between surviving and really thriving and finding a balance in life.
Fantastic. Thank you so much. And Linda, do you want to give us your thoughts about your journey? And Linda, I think you're muted.
My journey is similar, although it has taken several different paths along the way. I first experienced depression after the death of our infant son when at 5 months of age. And that was now over 30 years ago. So I spent probably 25 years searching for that. Oh, not necessarily cure, but how best to live a full life, as Michelle mentioned, and was not able to do so. And it was at the point at which my psychiatrist in Western Michigan said that he could no longer help me, that I found myself doing a self-referral to Michigan Medicine and the staff there and subsequent ketamine treatment, which has been, again, the difference between living a full life and really not worth much. So I'll give you more detail about that in a bit.
Thank you so much. So, Dr. Parikh, you're up, and I think let's go ahead and start the slides. And I'm going to hide myself, and then after you're done, you'll hand it off to Dr. Pasilio.
Well, hello, everyone, and thank you for attending. And especially, I want to thank Michelle and Linda for being able to talk about their journey. And I think we're going to hear a lot more about their journey later on. But my task is to
Dr. Parikh, I think you might have muted yourself. There you go.
no, the slides are not advancing, unfortunately, now. So sorry for the technical difficulties while we sort this out.
We're going to keep going. I should mention, I was going to say this before, I'll put it in now, that if anyone who's watching, sorry, I'm going to bring myself on camera here. If anyone who's watching has a question, you're going to use that Q&A function to submit it. And if you do have a specific person you'd like to direct your question to, please sort of note that in your question. So if it's for one of our folks with lived experience or for one of our clinicians, if you'd like to note that as well and when you enter your question. And thank you to everyone who entered questions when you registered. We were so amazed at the number of people registered for this event, and we're really grateful to everybody who's tuned in live and everyone who's watching this after the fact. So let's see if we can get these slides going. And
one of the great stresses of the modern day is the Zoom interview when something technical does not go well. But, we will rise above that, I hope. So let's see if, Kat, if we can, there we go. So you've already heard my introductions. So I'm a moody guy. I specialize in mood disorders, and I'm really interested in helping people find solutions that work for them. And one of these solutions, next slide, please, involves thinking about ketamine. And, we're here at the University of Michigan, and, it's good to be proud of where you're at, because ketamine was actually first created by a chemist in Detroit. Yes, in Detroit in 1962. It was part of a journey to find safer anesthetic agents. And believe it or not, the street drug PCP, which was not a street drug at the time, but was a new compound, was thought to be a promising anesthetic. And then naturally, we learned of some of the dangers of PCP, but one of its derivatives turned out to be ketamine. The Michigan connection to ketamine continues in that the first use of ketamine in humans was actually here at Michigan Medicine, and it was being developed as an anesthetic agent. And it became so popular around the world that the World Health Organization has declared it one of the world's 10 most essential medications. When you include how ketamine is used for anesthesia, for pain relief, for psychiatric disorders, it is used by hundreds of thousands of people every single day. But the story of ketamine in depression or in psychiatry in general is a much more recent story, just since the turn of the century. Now, one thing that I'd like to clarify up front is why doesn't a company develop this? Why isn't there actual approval by any government, that whether it's the American government's regulatory agency, the FDA, or Health Canada in Canada, and the European Medicines Agency, why don't they have a formal indication for ketamine in depression? Because I'm going to tell you about the evidence for it. And it's a very simple reason. Ketamine, being an old drug, is genericized. That means anyone can make it, anyone can sell it. And for that reason, no company is willing to take it to a regulatory agency and spend the money and spend the time to get it officially indicated. So this is one of the areas of medicine where we have a treatment which has excellent evidence, but doesn't have official government stamp of approval that it is useful for this disorder. But, the way medicine works, if there's good evidence, physicians and patients have the right to try medicines, regardless of any government stamp or not. So, next slide. There we go. So, how does ketamine work? I think we've all heard about various psychiatric drugs, particularly SSRI antidepressants, and we think that in those circumstances, one medicine affects mainly one neurotransmitter system, such as serotonin. But in fact, there are some medicines, including particularly ketamine, that work on multiple systems. And because they work on multiple systems, it's hard to know which is the most important system. But one of the biggest areas of action is that ketamine blocks something known as the NMDA receptor, which is associated with one of the main brain neurotransmitters, glutamate. And I'm going to tell you more about glutamate in a second. But I want to just get to the punchline. What is the role, what is the success of ketamine for depression? At least half of patients with severe depression respond really well to ketamine. And sometimes you can see that improvement or significant improvement even after a single IV infusion. If you only did it once, it would only last maybe for a week. So we generally have to give it a few times, and then to lock in the benefit, we often supplement it with more traditional antidepressants. So what do we know about glutamate? You've probably heard about serotonin, you've probably heard about dopamine, maybe you haven't heard about glutamate. It turns out that glutamate is actually one of the most, or in fact, the most prevalent neurotransmitter scattered through the brain. It has a function which is excitatory. It gets us moving, it gets the neurons acting. And it's released all over the brain. It doesn't have only one area of the brain that it affects. One of the key things that it does, though, is it's a bit like fertilizer for a plant. It promotes brain cell growth and connection. And the way that neurons connect with each other are through synapses. So it promotes those kinds of connections. And of course, glutamate is involved in many other things. So this is a complicated diagram on the left, but I want you to look at the pictures on the right. And imagine what you see there is a branch of a tree. And you see the first black square there. It says control treatment. It's the branch without much, very many buds on it. That is actually a branch of a neuron, and that has not had ketamine. If you then expose that neuron to ketamine, you'll find a bunch of new buds on that branch, which are depicted here with the yellow arrows. Those buds are where the synapses form, and the synapses are how neurons talk to each other. Ketamine induces the formation of these buds within hours of administration. And we think this way in which it enhances communication is actually one of the ways in which it truly works. I wanted to draw attention to the fact that we can think about ketamine's activity at a local level, that is an individual cell and how cells grow and how they connect, but we can also think about it in terms of circuits. Groups of neurons work together to perform a certain function. And these functions may be related to a specific behavior, they may be related to a specific symptom, and because of that, we can say, well, can we study not only the neurobiology of ketamine in terms of what it does to that system, but can we say, oh, if it works on this system, which makes us enjoy pleasure more, can we build on that by doing something else, maybe some psychological maneuver that also builds on that and strengthens that. So one of the most intriguing things is that ketamine for people with severe depression, not necessarily for people who are not depressed, ketamine allows for greater pleasure in the things that we normally find enjoyable. And interestingly, one of the most potent ways in which it enhances pleasure is in the pleasure of social interaction. This is a very new finding just published this year in the American Journal of Psychiatry, where they were able to look at several hundred patients who had received ketamine, and they saw many different symptom improvements. But one of the most striking was their ability to enjoy getting together and interacting with other human beings. Now, because it has such specific effects on different pathways, it also gives us a hint. Oh, if this pathway is important for depression, certainly let's use the ketamine to enhance that. But maybe we can then tag on some psychotherapy that reinforces that. And so this is where there's a lot of excitement and research going on about trying to find the right way that psychotherapy can work better with ketamine as a starter or as an inducement to the change that psychotherapy seeks to achieve. So how is ketamine given? Well, most commonly it's given through an IV, an intravenous method of delivery. Ketamine, as I mentioned, is an old drug. It's actually very cheap, but the whole process of delivery is not so cheap because it involves usually coming to a clinic or a hospital, staying for a few hours, being hooked up with monitors, and getting an IV. There is a different form of ketamine. Ketamine itself is what we call a mixture of right-handed and left-handed ketamine. And there is a purified form of ketamine, which is just the left-handed version of ketamine, which is known as Esketamine. And that one was patented and has been developed as a medication known as Spravato. That medication, Spravato, is available in a number of countries and is approved by the various government agencies for the treatment of depression. So one way to get ketamine is through an IV. The other way is to get esketamine, which is usually administered through the nose. Because this is manufactured as a liquid, that is, ketamine is manufactured as a liquid, there aren't any manufactured pills of ketamine, but some people try to take that liquid and put it into a pill or a dissolving tablet known as a troche. And so some compounding pharmacies will make that. That is not widely used because the absorption is not very predictable or very good, but it does have some utility. So, when people think about new drugs in psychiatry and they think about psychedelics and they think about ketamine, often they see pictures of spa-like environments, really beautiful, really seductive, and so on. Well, I'm sorry to say, mostly this is what it looks like. This is our actual ketamine administration bay, one of 4 that we have. And yes, it's in a standard hospital area. You have all the usual cardiac monitors, oxygen, resuscitation equipment, and so on. So this is the way in which it's administered. In spite of the fact that we don't have, wonderful candles and beautiful tapestries on the wall, even in this sterile medical environment, ketamine works pretty damn well. So how do we deliver it? Well, there's a standard dosing amount. I won't really read all the specific details, but there's a specific amount that is given based often on weight. It's given through a slow drip and an IV over about 40 minutes. And you monitor the patient not only through that, but for about an hour afterwards. And if you find after some infusions that it's not working fully, you have the ability to adjust the dose. But it's important to know ketamine is an anesthetic. So if you give too much, you're just going to put the person to sleep. And research has shown when you give too much and you put the person to sleep, it doesn't work as an antidepressant anymore. So there is a window of dosing that doctors have to find for each patient. Now, where are you going to get ketamine if you are interested in it? Well, the first thing to know is where the evidence is for ketamine is really about depression. Unfortunately, many people, many treatment providers have gotten carried away and are using ketamine for all kinds of things. There is promising research about ketamine for several other kinds of disorders. So I'm not saying it's totally inappropriate, but I think people have gotten carried away and are trying to use ketamine just for growth, like personal growth. Others are using it for, virtually all other psychiatric disorders. It's not for everything. Depression, yes. Uh, and that's the main indication, and that's where we focus on. And that depression could be regular unipolar depression, or it could be the depression that is part of bipolar disorder. So if you are going to receive ketamine and you go to a ketamine clinic, uh, because ketamine is widely used by many different specialties, you should be careful to make sure that not only is the person competent to give ketamine from a medical perspective, but there's adequate psychiatric backup and understanding. So if you go to a place where there's no psychiatrist involved in the assessment, it may be perfectly safe because somebody who, for instance, is an anesthesia specialist is certainly extremely competent to give ketamine, but it's really important to have psychiatric input in deciding how to give the ketamine and how to especially monitor someone who's getting ketamine. IV ketamine, is often not covered by insurance companies. Sprayvato, the intranasal form that is FDA approved, is often covered by insurance companies. And so that's another consideration about where and when and how to get ketamine. Now, a second important issue is when do you turn to ketamine? The important thing to know, as good as ketamine is, we actually have a number of other treatments. And this slide is actually from the main CANMAT treatment guideline for depression. And here, what this slide says is if you've started on an antidepressant and there's a poor response, what do you do? There are three options when the first medicine is not working. One option is adjust the dose or optimize the dose. A second option is you switch to another regular antidepressant. And a third option is you can give a helper medicine, often known as an augmentation agent, as a next step. We normally recommend, as do most ketamine clinics, that if you are going to get ketamine, you should have tried at least 4 other things before you go to ketamine. Those 4 other things might include 1 or 2 dose increases, maybe a switch of antidepressants, and a trial of 1 or 2 of the helper medicines. Only when you've tried these other alternatives and they didn't help, that's when you try ketamine. The specific list of helper agents I thought I would share with you. And these helper agents are divided into first line and second line. The first line agents are the ones that people should try before they even get to ketamine, either aripiprazole or brexpiprazole, which are now widely available around the world. It's after you've tried one or both of those and maybe 1 or 2 other antidepressants that you should say, is ketamine the right thing for me to do? And even then, you can see in this table of second line agents, there are many other agents listed. So it's not automatic that one should go to ketamine, but that's the positioning of it. Now, we've talked about ketamine and esketamine. So what's the difference? I made one analogy, and that is ketamine is the original compound, and it's actually a mixture of left-handed and right-handed ketamine. And that's called, in medical terms, a racemic mixture. And the right-handed and the left-handed are simply R and S. The esketamine is just the left-handed version, the S enantiomer. The way in which research has been done has really been determined by who funds the research. The research on ketamine, the mother compound for depression, has largely been funded by academic institutions and by some foundations and by the government, not by any large pharmaceutical companies because no one owns the patent on it. As a result, The number of studies is somewhat less of regular ketamine, and the size of the studies are somewhat smaller. That said, IV ketamine has still many dozens of studies that demonstrates how it works, how well it works in depression. But as I mentioned, because it's not regulated, it doesn't have the stamp of approval from the government, it's not officially indicated, but it's perfectly reasonable to use based on the medical evidence for depression. On the other hand, Esketamine was patented by a pharmaceutical company, and because of that, they have invested many millions of dollars to do many large studies to establish the efficacy and safety of that compound, also known as Sprayvato. And that one is, of course, administered as an intranasal spray. How is it administered as an intranasal spray? Well, there's a simple device like this. It has two doses, one for the right nostril, one for the left nostril. And depending on the total dose of esketamine desired, you might use one of these devices or several of these devices. And in both cases, whether you're getting IV ketamine or intranasal ketamine, typically you get it twice a week, at least for 4 weeks, as the initial trial to see if it's going to work. Which one is better? Well, that's a really important question. Could ketamine be better than esketamine or vice versa? Actually, there have been no head-to-head studies where people were randomly assigned to get one or another. There was a large study, which is called a meta-analysis, where they took various studies of ketamine, various studies of esketamine, and they said, what's the main outcome of just the studies with ketamine? What's the main outcome of just the studies with esketamine? And then let's try to compare them. And there was a suggestion when they did that the IV racemic ketamine was somewhat better. Well, we want to know really which is better. And I'm proud to say that we are one of 3 academic sites led by our colleagues at Yale University, where we're going to be studying which is better, the IV ketamine or the intranasal esketamine. And in this study, which will be starting in February 2025, people will come in who are clinical patients needing ketamine. We'll evaluate them and we say, yes, you're appropriate for ketamine. Would you like to participate in this study? And in this study, you'll either get 8 sessions of IV ketamine or 8 sessions of esketamine. And that's it. A 1-month study. That's it for the official research part. After that, you just get whatever is good for you. So you can continue to get esketamine or IV ketamine. And we want to know how you do, and we'll continue to treat you for another 6 months. So this is an upcoming study, which we hope will establish, which is better. So what do I want to conclude with about ketamine and esketamine? Well, I am impressed as a psychiatrist with 30 years of experience, having used many different kinds of treatments, having used transcranial magnetic stimulation, TMS, electroconvulsive therapy, ECT, having actually used IV clomipramine, which is one of our older antidepressants. Ketamine is different. It works to a greater extent. It's faster working. And we didn't have time for it today, but it seems to also be really good for abolishing suicidal ideas. And that effect on abolishing suicidal ideas is not just because it makes people feel better. It actually has an independent effect so that people don't think about suicide. It's really an exciting treatment. But before I conclude and say, yes, of course, it's an essential treatment for depression, I have to remind you, it works really well for half the people. It works somewhat well for another 20 to 30%, but for a good quarter of people, it does nothing. And there are some limitations, there are some concerns, and we'll hear more about it from other speakers today.
Great. Dr. Basilio, you're up next. And I think we maybe have skipped ahead a slide or two.
Think so. Can you go back a couple of slides for me? All right, perfect. So thank you guys so much for joining us tonight. I am really excited to be here. Again, my name is Rachel Pasilio. I'm a clinical assistant professor in the Department of Psychiatry here at Michigan Medicine. And I have experience with evaluating patients with treatment-resistant depression for ketamine treatment, administering IV ketamine treatment and prescribing oral ketamine. And my primary research interests are in safer delivery of ketamine and looking into how ketamine is being delivered in the community. So I'm going to be focusing mostly on side effects, safety, and then treatment outcomes for both depression and then for other conditions. So some of the measures taken to ensure safety before, during, and after ketamine treatment. Practices can vary widely in the community, so this will largely focus on how we deliver treatment here at Michigan Medicine. But this is a good template for patients in knowing what to look for from an outside clinic when deciding to potentially pursue this treatment elsewhere. Generally, ketamine is a very safe and potentially highly effective treatment for the appropriate patients, but it's not a good fit for everyone, like Dr. Parikh mentioned. Like I said, I'll also touch on some of the potential side effects of treatment, some possible long-term effects, and then data on overall treatment efficacy for depression, and then some other conditions for which evidence is emerging and ketamine is being offered for treatment in the community. In the pre-treatment phase, appropriate patient selection is likely the most important factor in ensuring that ketamine is a safe and potentially effective treatment for a specific patient. An experienced clinician, ideally with psychiatric expertise, should be performing a thorough evaluation to ensure that ketamine is an appropriate treatment option based on their psychiatric symptoms and history. During this evaluation, a psychotropic medication review should be performed, looking into their current and prior medications to determine if a trial of a traditional antidepressant or another medication may be more appropriate before pursuing ketamine treatment, and also to ensure that medication interactions are minimized. There are certain medications like benzodiazepines, gabapentin, and lamotrigine, among some others, that may interfere with the efficacy of treatment, so these may need to be tapered or discontinued, but in general, it's safe to continue most other psychiatric medications, and that's often recommended in conjunction with ketamine. A thorough medical workup should also be performed prior to treatment with ketamine. So just general medical clearance for all patients should be obtained. This usually will include vital signs, laboratory studies, pregnancy tests for women, electrocardiograms, and then possibly other tests depending on individual patient factors. And medical history should also be reviewed to rule out any contraindications to treatment. So there are relatively few contraindications to ketamine treatment, but these are important and include current or prior history of psychosis or psychotic symptoms, active use of certain substances or an active substance use disorder, pregnancy or breastfeeding, or unstable cardiac disease, high blood pressure, or obviously prior adverse reactions to ketamine in other settings. So in the treatment phase, there are a variety of mechanisms to ensure treatment during safety during treatment itself. As Dr. Parikh discussed, the starting dose for ketamine is typically standard for most patients, but in general, the lowest effective dose should always be used. Doses are used that the doses that we're using for psychiatric reasons are substantially lower than those used for anesthesia, usually 1/10 or less. They are often increased during the treatment course at the discretion of the prescriber based on the response and tolerability, but generally not to exceed 1 milligram per kilogram, like Dr. Parikh mentioned. Selecting the route of administration for ketamine is also an important individualized decision. IV ketamine and intranasal esketamine have the most data for safety, and these options should be utilized for the majority of patients because there's the best evidence for use. There are other formulations available from compounding pharmacies or other specialty pharmacies, and the FDA has actually recently issued a warning about these specific formulations due to a variety of potential risks, including variability with dosing. So these are generally reserved for use in complex cases and should be reserved for prescribing by an experienced psychiatric specialist. Ketamine should also be administered in a setting with a trained medical professional present to check vital signs and assess psychiatric symptoms before, during, and after dosing. It's generally very well tolerated by most patients, but the treatment can be a physiologically and psychologically intense experience, especially in the earlier treatments before people have kind of gotten used to it. It's often not needed, but the availability of a medical professional for assessment is important. And at this point, use outside of the medical setting or at-home use is generally not recommended for most patients. There are some potential side effects or adverse events that can come up during treatment. Like I mentioned, most people tolerate the treatment quite well, and side effects during treatment are transient and typically mild. Most commonly, this includes nausea, headache, a feeling of dissociation, or a sense of feeling detached from reality, as well as sedation. The most significant side effect that we need to worry about medically is typically elevated blood pressure, but generally this is not a problem if blood pressure is well controlled with medications. And medications can be given prophylactically to help mitigate any adverse effects during treatment and prevent those from interfering with the treatment course. So symptom tracking should be performed throughout the treatment course. Monitoring the objective response to treatment over time is necessary to determine if the treatment is efficacious for the patient, determine the need for dosing changes, and then to guide the decision to continue versus discontinue treatment. And like Dr. Parikh mentioned, it's really important to have a psychiatric specialist involved in this process, because there can be significant nuance in terms of teasing apart psychiatric symptoms. Towards the end of the kind of index or initial course of treatment, planning for the remainder of the course and then thinking about relapse prevention are important next steps. So there is a standard index course protocol, as Dr. Parikh mentioned, usually somewhere between 6 and 8 infusions over a couple of weeks. But there aren't yet clear guidelines about how to discontinue taper or choose to continue with ongoing maintenance treatment. Maintenance treatment is becoming more and more common, but the evidence that we have now suggests that it generally should be reserved for cases in which other options have been exhausted. And this should be managed by an experienced clinician with experience specifically in prescribing ketamine long-term. And then, like Dr. Parikh mentioned, ketamine is generally considered an adjunctive treatment for depression, so it's in combination with other medications. The duration of response to the ketamine treatment can be variable, so other antidepressant agents may need to be utilized, during or after the treatment course. So considering increasing current antidepressant medicines or introducing new agents with novel mechanisms should be considered as the treatment course is wrapping up, to ensure that depression doesn't return after ketamine is discontinued. So in discussing maintenance and long-term effects, I will preface all of this by saying that a lot more study is needed to determine the effects of long-term use of ketamine for depression or for other psychiatric illnesses. And we need more information about the potential development of tolerance and the risk of dependence or abuse of ketamine. Studies have demonstrated safety and continued efficacy of ongoing ketamine and esketamine treatment without evidence of emerging safety issues or adverse effects. There have been a number of smaller studies with IV ketamine, as well as a large study of esketamine in which patients had been using the medication for over 4 years that support this. There are several medical or other problems that can arise with inappropriate heavy or chronic use of ketamine, such as cognitive dysfunction, urinary problems, or other side effects, but these have not been reported with the standard therapeutic use of ketamine or esketamine, even with patients who've been taking the medication for several years. Likewise, there has not been any evidence to demonstrate that tolerance has develops with ongoing appropriate use of ketamine. Dose escalation is often not needed for maintenance or is minimal over time. There isn't any evidence to suggest that ketamine misuse after treatment for depression is a significant concern. This is particularly true when the treatment is delivered in a supervised setting, but this may become a bigger issue with the increasing availability of at-home use. So extra monitoring may be appropriate for patients who may be at risk for misuse if they are using ketamine outside of more supervised settings. And then lastly, I'll just touch on kind of efficacy and treatment outcomes in general. Ketamine can be a rapid and highly effective treatment for depression. A single infusion response rate is around 50% in terms of improvement of symptoms and 30% for full remission of symptoms, with the average time to relapse around 2 to 3 weeks. These numbers are fairly consistent following the initial course or sequence of 6 to 8 treatments that most patients receive. And these are fairly similar to response rates for ECT, which has traditionally been considered to be the most effective treatment for depression prior to the increase in use of ketamine for this disorder. This is especially kind of striking as many of the patients who were involved in these studies had failed a number of treatments and had not responded to 2, 3, 4 or more medications or other interventions. And there are a variety of other indications for which ketamine is being studied. And like Dr. Parikh mentioned, many clinics in the community are offering treatment for a variety of different disorders with varying levels of evidence. So the most studied conditions include PTSD, anxiety disorders, OCD, and alcohol use disorder. And the preliminary evidence suggests possible efficacy for these conditions. So it is reasonable to consider in cases when other evidence-based interventions have failed. But these typically, ketamine shouldn't be used in routine clinical practice for these conditions based on the evidence that we have now. The latest compilation of clinical trials suggests that there really is not sufficient evidence for use regularly for disorders other than major depressive disorder, and shouldn't be used routinely in clinical practice for things other than treatment-resistant depression as of right now. That being said, many trials are ongoing for a variety of disorders, and new evidence is emerging very quickly. So ketamine may be incorporated into the standard of practice for some of these other conditions in the relatively near future. But patients should be discerning about seeking treatment for indications that haven't been well studied as of now. And that is all I have. So I will pass it off to Dr. Geller.
Thank you, Dr. Basilio. Thanks, Dr. Preek, and thanks to everyone for being here. My name is Jane Marie Geller. I have a master's in contemplative psychotherapy, and then I finished up my adult psychiatry training here at Michigan Medicine last year. I'm currently a child psychiatry fellow. I've been involved in some research projects looking at ketamine in mental health and have experienced providing ketamine treatment to patients. One of my primary clinical and research interests is the use of ketamine to facilitate recovery as part of larger treatment plans, including psychotherapy. And I'm also very passionate about bringing information to the medical and the general community. So I'm excited to be here with you guys tonight. I'm going to focus on some newer and less formalized ways of using ketamine, including ketamine-assisted therapy, ketamine treatment for adolescents, and I'll talk briefly about online ketamine companies that offer in-home use. And I might go a little bit quickly through my slides so that we have time for questions. I can see all these great questions coming in. So first, I'm going to discuss ketamine-assisted psychotherapy, sometimes referred to as CAP. This is a term, the definition for which is not entirely agreed upon, but generally it means that there's ketamine treatment being offered in one of the routes of administration discussed by Dr. Preek and Dr. Basilio at some point, and then psychotherapy at another point. So it could be that the ketamine is done one day and the psychotherapy is done later that day or the next day or several days later. It could mean that the provider who is providing the ketamine for the patient, IV or IM, is just in coordination with the therapist, and they're talking about how the patient is doing. And it can also refer to the specific modality in which the patient is taking the ketamine in the therapist's office. It's prescribed by a provider, but then there's like a prolonged psychotherapy session. I will note here that in contrast with Spravato and even IV ketamine that are really delivered with specific parameters, and in the case of Spravato, by parameters set forth by the FDA, CAP has not been well studied, has no oversight by regulatory agencies, and therefore the practices vary quite widely, and the evidence base supporting them is minimal. Dr. Preek touched on this briefly, but the idea behind ketamine-assisted therapy is that there's some kind of synergy or combined effect between the way that the brain is altered by the drug, so increasing the neuroplasticity, decreasing defenses on the part of the patient, decreasing depressive symptoms, and that works in concert with the psychotherapy so that they can both work better. Again, there's really no standard treatment protocol, so there are many ways that the structure varies, including the type of ketamine administration, sometimes oral, sometimes intramuscular, IV, the number of therapy sessions that are provided, the number of ketamine administration sessions, and then kind of the temporal relationship between those two. And although there's no high quality evidence for or against CAP that we have so far, for the most common problems that patients see a psychotherapist or a psychiatrist for, like depression, anxiety, really the best evidence says that when those things are working together, that's when we have the best outcomes compared to either of them alone. And as was mentioned by Dr. Basilio, the outcomes of these treatments are probably really highly dependent on choosing the right patient and using it for the right reasons. Probably very dependent on the therapist themselves, the relationship that the patient has with the therapist, and then the provider making this really a part of a larger treatment plan and strategy for the patient. So the ketamine not really being the only thing that the patient's relying on to get better. So our general advice to patients who are thinking about seeking ketamine-assisted therapy in the form of taking the ketamine in a therapist's office is to find a therapist who's specifically trained in CAP. Of course, find a reputable psychiatric provider for the medication who's familiar with ketamine treatment and the issue that you're coming to them for. And if you're prescribed other medications, you're already in treatment, of course, recommend consulting with your healthcare provider before making any changes to your treatment plan at all. So another special use of ketamine that I'll discuss is its use with adolescent populations, which is something I think about pretty often, given the mental health crisis facing youth, and the many patients that I see in my office with depression that's really resistant to the first line or even second line treatments and still really suffering. So there have been some early and very small studies looking at ketamine to treat depression in adolescents, both using IV ketamine and Spravato nasal spray that Dr. Parikh and Dr. Basilio talked about. The studies looking at IV ketamine in adolescent depression do look somewhat promising, but there's really only been one study looking at the use of Spravato, which was for depression in adolescents at high risk for suicide. There's really only preliminary data available from that. It shows like kind of so results, so a lot more needs to be done to find out whether this is an effective and safe treatment for teenagers. Though again, kind of based on really early studies, there's some evidence that in certain situations, IV ketamine treatment is more likely to work for adolescent depression, including a shorter duration of the current depressive episodes, similar to adults, fewer medication trials before the ketamine, being on certain medications during the ketamine treatment, and the absence of a history of trauma. So probably all pointing to just the depression or the depressive episode having been less resistant to treatment in the first place. And then anytime we're talking about younger people, there's a concern about the impact of the medication on the developing brain. And there have been some studies to suggest that in adults who have used ketamine recreationally and probably in high volumes as teenagers, that their brains look a little bit different from adults who hadn't used the ketamine, although whether the ketamine really caused that isn't clear. So a lot of work left on safety in adolescents. So basically, there may be a role for ketamine in adolescents with depression when other first-line treatments have failed. But the potential risks versus the potential benefits of this treatment with each individual patient and family should be weighed extensively, in each particular case and by a professional with expertise in both ketamine and child psychiatry. So lastly, I'm going to discuss online ketamine companies, of which there are many. You may have seen them advertise, these companies that are saying that they will give you, they'll do telehealth visits and then mail the ketamine to you and deliver the treatment that way. Again, there's very little oversight of these companies and services, and we advise using a lot of caution. If you look at some of these sites, there's a ton of really bold claims made about the many problems that ketamine from their service can solve for you. So just be mindful of the fact that there really is very little data to support ketamine's use in anything other than depression, the suicidal ideation that has been discussed. And that even in the studies that have been done with ketamine and the way it's delivered in academic centers now is in a very controlled, very supportive clinical setting where extremely comprehensive evaluation is done. There's a whole team of mental health professionals that are caring for the patient throughout the treatment. This is not that situation. If you do decide to use one, though, it's really important to look at what level and kind of services are being provided. Generally, you're looking for a service that uses actual psychiatric providers that are going to do a thorough intake with you, a thorough evaluation to get your entire history, get a picture of your current symptoms, what's going on, provide adequate follow-up throughout the time that you're using the ketamine. So a provider who's checking in on you regularly, not just an app that you're typing in a number to or questionnaire you fill out between the doses. You may also consider, if you don't already have one, finding a separate psychiatric provider to see in person for medical advice to support you around this process. Those are references I use. And well, thank you for your attention. And I'll turn it over, I think, to the...
Yeah, and thank you, Dr. Geller, so much. This is Kara. Thank you, all three of you who presented. And I think we can stop sharing the slides so we can see Michelle and Linda. And I think Michelle was going to go first and talk more about her journey and how you came to be treated at U of M with ketamine and what that experience is like and really what it actually the experience of treatment is like itself. So, Michelle, go ahead. You're muted. It's not a Zoom call without someone being muted when they're talking. There
Been
you
a
go.
long time since we've been on Zoom, so yeah, I'll do my best to share my journey. And like I said, I was looking at some of the questions and answers, and I'll try to touch on some of those if they applied to my journey and my story as well. So, I am a 41-year-old female who is an educator. I work in elementary education. Like I shared kind of in my at the beginning of the presentation, depression, anxiety are something that I've struggled with for a very long time. Even as a young child, I had a lot of negative thoughts about my personal appearance and my worthiness. As I moved into adulthood, those things compounded and became even larger. And what ended up happening is it resulted in a lot of failed or difficult relationships, both romantically and socially. Um, as I moved into my career, I felt like I was living every day in fight or flight mode. Um, I am an overachieving personality, so I was having a very hard time finding a balance between life and work. And because of that, again, it resulted in failed relationships. Um, I have been in psychotherapy since my late 20s. I have an amazing therapist who I still continue to see who has given me an amazing box of tools. I also love knowledge and I love brain research. So I've done a lot of my own thinking and I'm always eager and hungry to learn more about how the brain works and how and why am I the way that I am. So even with all these tools in my toolbox, I was still finding myself having a hard time um, being in control of my emotions, being in a space where I could engage in and foster and hold healthy relationships. And I just felt like I was surviving. I really wasn't living and enjoying life. Every day was a list of tasks to hurry up and get done. Um, Over the course of the last few decades, I've seen my antidepressants originally started being prescribed by my primary care physician. Um, in my late 20s, when I decided to pair that medication with psychotherapy, then it got transferred to a psychiatrist at the office where I was having my psychotherapy done at. What I started to feel like was a science experiment. If this one doesn't work, let's try this one. Or if this one doesn't work, then we'll do this. And so that went on for a very long time. I had a hard time finding a provider who would listen to me and understand my symptoms. I feel like I'm very in tune with my body. I'm very conscious about my health overall, and I had a hard time finding a provider who would listen to me about the symptoms that I was experiencing. So what would happen was that they would put me on a new antidepressant, and one of two things would happen. I would start gaining weight, or I would experience sexual side effects, both of which were not ideal for a young woman. So I would stop taking them. And this cycle went on for quite a while. And right around my 40th birthday, I decided that I was sick of living this way, and I felt that I didn't have the opportunity to engage in a lot of things that I had originally wanted for my life because I was so held down by my depression and by these negative thoughts that plagued me every day. And so, in conversation with a friend, she was telling me about another mutual friend who had went and engaged in some um, a psilocybin experience. And so then I started researching that. I was looking for alternatives because I knew that the typical SSRIs weren't working for me. Um, and during that search, I landed upon ketamine. So I started reading as much as I could. I started listening to as many podcasts as I could. I was nervous because even though it's been used in the UK and in other places for a while for depression, it was somewhat new in the United States. And even today, it's still something that I think people don't know a lot about. And so it was a little bit scary. But when I was able to see that the University of Michigan had this ketamine clinic, I know that a lot of the most brilliant minds sit at the University of Michigan, and I felt confident that um, I could go there and receive this care without that worry. So I spoke with my therapist, who spoke with the physician's assistant who was in charge of my medication treatment at that time. I was able to submit my application to the ketamine clinic. And after a few phone calls and phone interview or Zoom interviews, I was accepted to the clinic. And within just a few treatments, I remember sitting there and thinking to myself, if more people knew about this, I just think they might not waste as many years as I did living such a small version of what I thought that my full potential was. Um, One of the things that the doctor spoke about during the presentation was something set and setting. So if you listen to any podcast or if you're trying to find out any information about ketamine, a lot of the things that people will talk about is set and setting. Um, the University of Michigan Ketamine Clinic is you go there and you feel safe because it is a medical facility. You have registered nurses who are sitting there and monitoring you during this process. And the beautiful thing about the ketamine infusion is that the infusion is titrated over time. And so they have the control to, if you are having negative side effects, slowing down that titration. The other great thing is you get to meet with amazing doctors like Dr. Parikh prior to your treatment and after your treatment, and have them on your team as you move through this journey. Um, so again, I say all of that to say that I'm so thankful for the opportunity to have engaged in these ketamine infusions at the University of Michigan because I truthfully believe that for the first time in my life, it's allowed me to be in a mental space where I can have healthy relationships. I have healthy relationships at work. I've never had that. I've been a teacher for 18 years. I worked in the same building for 18 years. And some of my work in that building is coaching adults. And that was really hard for me. And in the last year, I've just been able to make so many meaningful connections. And I enjoy having those connections and conversations at work, where before I didn't, I would avoid them. I'm also in the healthiest romantic relationship I've ever been in my life. And I really attribute that to the ketamine helping me calm my brain down, stop those negative thoughts, and be able to use all those tools that my therapist put in my toolbox um, to help me get to this point.
That's amazing. Thank you so much for sharing so much. And I'm going to have a couple questions for you afterward, but let's give Linda a chance to talk. So, Linda, if you want to unmute, there you go, and come on camera. And tell us a bit about your journey and maybe how it differed from Michelle's or similarities too. And Linda, I want to turn your camera on. And if you're talking, Linda, we can't quite hear you.
I'm not saying anything yet.
Great. Okay, no worries.
There
There
we
she
go.
is. Wonderful.
Well, my story is quite similar in many respects, but in others, I'll give you my synopsis. I'll give you a before, during, and after ketamine. My before experience with ketamine started like Michelle's back when I was probably undiagnosed, but in my 20s, but certainly in my mid 30s after we had our third child, who then subsequently passed away at 5 months of age. And at that time, my OBGYN prescribed Zoloft. for me, which did not work. And then he referred me to a internal med physician who prescribed some other meds for me, who then subsequently referred me to finally a psychiatrist for appropriate diagnosis of my depression. And what entailed from there was several years of seeing a psychiatrist and a psychologist and trying, I'd have to count back, but over 10 different combinations of different medications, oral medications, over the years that were not effective. I'm 64 years old, a retired nurse, used to work in critical care. So I had a little bit of background knowledge about ketamine, but nothing in terms of its use for psychiatry because critical care was my background. My depressive symptoms were what you'd expect for someone. I actually think I have the full gamut of symptoms that included, sadness and irritable mood and lack of motivation, and self-care was lacking, and I'd sleep most of the day if I could when I wasn't working. I'd put on my face, when I went to work, and when I came home, I would crash and I'd get up and repeat and do the same thing, which really isn't conducive to much of a life at all. So I actually was, I think I mentioned in the beginning, I came to Michigan Medicine a few years ago, actually, when my West Michigan others beyond that we knew had a good reputation. This is my husband and I, and as well as my children. I have two adult physicians, children, not in psychiatry, but certainly have had background or education in that during medical school. So was able actually to self-refer into the U of M psychiatric care program. So I actually got to see a psychiatrist attending for a period of time until he was no longer with the program anymore. And now I'm being followed by the resident clinic. And it was being followed by the resident clinic at the same time that one of my sons also has a colleague who is a psychiatrist in another state who first introduced him to ketamine just in general, because my son was talking to him about me and my symptoms and how refractory they were to not only medication, but we also tried TMS and ECT, both without any change in my symptoms. And again, that was in the West Michigan side of the state of Michigan. So my son, kept working on me. So I was a little reluctant at first to even consider it. And then we talked to the staff at U of M, and I talked to the psychiatrist that I was seeing at the time. And we went ahead with the referral into the clinic, was sent, interviewed, and accepted into the ketamine clinic. And that was a little over a year ago. And I did very well, responded very well to the ketamine after the first initial dose. That is to say, my first dose, as I experienced it, did not go well in my mind. I was given great education ahead of time, what to expect, what I, should bring along. And so I brought a pair of noise canceling headphones. I downloaded a ketamine playlist, which is awesome for distraction. And I also brought a mask for my eyes to block out any light. But halfway through that first procedure, I had a panic attack, which I've never had a bona fide full-blown panic attack before. And it took a couple of the staff, and I'm thinking at least one of the physicians was right there holding my hand through the whole time. And we were able to make it through without slowing down the dose so that I could keep on track for the next time I came in, when I was understandably a little apprehensive, but at least I knew what to expect. So I ditched the eye mask because one of my complaints was I opened my eyes and I couldn't see because I felt like I couldn't move with the ketamine on board. But having the noise canceling headphones with the ketamine playlist was all I needed. I just closed my eyes, told myself, as other people had told me, that, you've got this, and to just let my mind go and experience the ketamine and let it do its job that it would do it. And it does, it has. I did well, as I mentioned, for receiving the ketamine and weaned off in February of 2024, but I relapsed in June. And so, again, I'm still in the U of M system. And so we decided to amp up again. And so I am currently receiving, I went through another sort of loading dose, so to speak, in terms of to get, my blood levels back up where they needed to be. And then we are now in a maintenance phase of every 3 weeks. I am continuing to get ketamine for a period of time that we'll assess each time when I go in. So that has made things go very well. And I'm happy to say that I feel well, doing well, and happy to be here.
Thank you so much for sharing that. And especially that it's not a bed of roses for everyone, right? That it does have perhaps its ups and downs. But thank you so much. I'm going to invite all of our experts to come back on camera and we'll start some Q&A. Thank you to everyone who has submitted questions. And we've gotten so many. I'm trying to read them all and say, okay, we've already talked about that. Let's get into some things that we haven't talked about. For our faculty experts, I've had several people ask, why are we requiring someone to have gone through what Linda and Michelle went through, which is multiple medications not working, before saying, yes, let's try ketamine? What is the current thinking on why we need to do that?
Well, perhaps I could answer that. So let's say you had a headache. Do you take a Tylenol or do you go straight to morphine? Right? The idea is you take something simple, cheap, easy, and safe first, and you try it. And we have a long history with traditional medicines, and most people, believe it or not, most people actually get better with traditional psychiatric medicines. It's for the people who didn't get better that we have to use alternatives, whether it's TMS or ketamine or something else.
And I will add, I think this might answer one of the other questions that's been asked, is there can be considerable costs associated with these treatments, aside from, that they're newer and the time investment. And so, like Dr. Parikh said, there are inexpensive treatments that insurance is regularly covering.
Yeah, and actually I was going to ask about that, and if you could elaborate on that, maybe Dr. Geller and others, and maybe Linda and Michelle, if you're comfortable sharing what your insurance journey has been, because I think that is a question people have on their minds is how do I get covered for this? Am I going to be able to get covered for it? And what's the process of petitioning, to have that coverage?
I'm
My
actually,
sorry, go
sorry,
ahead.
go ahead, Linda.
That's all right. My insurance from the west side of the state has covered everything except the physician fee. Up to my deductible, of course. I do have a deductible to pay, which we all do, I'm sure. But it's been very generous that way.
Mhm. And I've experienced the exact same thing. Fortunately enough for me, my insurance does cover everything but the physician's fee. And I'm very, very thankful for that. And obviously, like Dr. Parikh said, you're getting a hospital type sterile setting. So, and you're getting monitoring by those who have the training to do so. And you're in a very safe environment, which I think that obviously there's a cost that comes along with that.
Dr. Parikh, anything about the insurance sides of things?
The insurance varies from company to company and state to state. And I think that increasingly many insurance companies are saying, wait a minute, there's pretty good evidence now, and their customers are telling them this works. And you know what? They're also discovering that it's a lot cheaper than being hospitalized or having some other kinds of treatment. So I think we'll see much greater acceptance of this by insurance companies over time.
And the Spravato, I think, perhaps more likely to be covered. Dr. Geller's nodding.
Yes, correct.
So finding a clinic that will offer that is perhaps an option if someone is not able to get the coverage for the full cost of the IV based ketamine. Okay, got it. Another question that we got a lot is sort of this idea of depression returning after someone. So, Linda, you mentioned the relapse, and so this idea of how, how often does that happen, and what is the recourse if someone does relapse?
Dr. Pacilio, do you want to handle that or?
Sure, I can take that. So like I think a few of us mentioned, it can be pretty variable in terms of how long the effect will last for any particular patient. Some patients have an index course of a few sessions, and they will stay better for quite a long time. Part of the reason why it's important to make sure that we're adding on additional medications and adjusting other things while we're also using the ketamine treatment is to help prevent relapse. But if someone does end up having a relapse, like Linda mentioned, if we know that ketamine works well for them, we can always do a repeat course. And oftentimes that is successful in getting them back on track again. And if it seems like ketamine is working really well for someone and other medications don't seem to be helping in the interim periods, then that maintenance is an option and something that it can be spread out over time potentially. It doesn't necessarily need to follow the twice a week course forever, but spread out 3 to 4 weeks or sometimes even longer. And keep people in remission for more extended periods of time. So there's a lot of different strategies to prevent relapse, and it's really very individualized based on kind of any specific person's initial response to the treatment, and then how they respond to the treatment in combination with other adjunctive medicines.
Great. And actually, while you're on that topic and while we have you unmiked, unmuted, the question came in about other things people should stop taking or could continue taking while they're on ketamine. So I think there was a mention of lamotrigine and gabapentin, so that's Lamictal and Neurontin, being ones that would need to be stopped. Are there other things that one should not be taking, or other things like supplements and things like that you have to go off of, or do people typically stay on most of their other medications? You actually did a study, Dr. Pacilio, that talked about birth control and the importance of women of childbearing age considering taking birth control while they're.
Yeah, I can touch on that as well. So typically it's benzodiazepines or gabapentin, which has a similar mechanism to benzodiazepines. Usually chronic use of benzodiazepines is what we're concerned about in potentially reducing the efficacy of ketamine. It's not necessarily something that we have to absolutely discontinue, but maybe reduce the dose or hold doses prior to treatment to help enhance the response. Lamotrigine as well, we may just need to reduce the dose. It kind of depends on the particular person and the reason that they're taking the lamotrigine, but those are the medications that we often want to eliminate before treatment. Cannabis is another thing that we want people to be ideally avoiding when they are getting ketamine, just because it's not something that's going to be helping treat their depression for the most part, and the ketamine is just going to be less likely to work if they're using cannabis excessively. In terms of other medications, other SSRIs, it can be used in combination with most other antidepressants, including things even like tricyclic antidepressants and MAOIs, which have a lot of medication interactions potentially. So there are a lot of options for other medicines that can be used in combination with ketamine. And we do recommend, especially for patients who are going to be on ketamine longer term or who may be at risk of potentially becoming pregnant at any point when they're getting ketamine, making sure that they're using a reliable form of contraception, or remaining abstinent during that initial course, to prevent pregnancy, since that is one of the contraindications for ketamine.
Great, thanks so much. Dr. Parikh, there's a couple of questions about sort of the science of the non-responders. Do we know much about why people might not respond to this?
Unfortunately, we don't. We've done one study known as the BioK study, which we had 75 patients whom we gave 3 infusions of ketamine to, and we were looking to actually create 2 groups: people who responded, people who didn't respond, and we did blood tests at several points, and we're looking for biomarkers. And the results of that are not fully analyzed yet. We have some preliminary biomarkers that look like they may be associated with response, but we even if we have those tests, we don't have a full explanation. But from a clinical perspective, I might say that the person who is totally unable to experience any kind of pleasure or relief at all, they're the hardest to find anything that restores vitality. So if someone might, for the past month, they may be really in a terrible shape where they can't experience anything. But if 6 months ago they were able to do that, then it shows that the brain's capacity to recover and experience positive emotions is still intact. And then the ketamine can come in and help restore that. But if someone has had 10 years of, just totally being sort of zombie-like, without days here and there or weeks or months of feeling, some joy, then that's a harder thing to fix.
Got it. Thank you so much. A question for our 2 patient experts, talking about what people who are maybe the loved ones, the friends, the neighbors of someone who is going to pursue ketamine therapy, what they can do to support the patient. I know that there's a restriction on driving, for example, so giving them a ride, right? But what other things, have helped in your lives to get support?
I think that for me, one of the biggest things is education. So I think that what's amazing about tonight's webinar is that there were so many people interested in finding out the medical benefits of ketamine used for this purpose. I think that there is a lot of misinformation out there in the media. So for someone who's of the age of that, I'm not married, my parents are driving me to these treatments, that was scary for them. They had a lot of questions. So I think just explaining to people how important this journey is to you, and how it, like Linda has talked about, and like I have talked about, how it's a difference between really living life and surviving life. Um, Maybe will help get those loved ones on board, because and even my parents have said to me they can just tell the difference overall in just my affect. Like, I don't always look like I'm in fight or flight mode. And they love seeing that version of their daughter again. So.
Linda, how about you?
Very similar. The biggest things for me was making sure that I had somebody that could take me, which almost always was my husband since he's retired. But there were those occasional times when I had to scramble and find a friend that was able to take, not only because it's a drive, it's a 5-hour driving time plus the time, that we're down there. Plus then they have to stay with me for 24 hours, or somebody has to. In terms of
So it's a commitment.
it's a commitment, if my spouse is not available to do that. So that was probably the biggest thing. The rest of my family, as soon as they knew, because almost everyone in my family has some sort of background knowledge in healthcare, they were on board right away. They might not have known all the little details and nuances, which we could talk about, but they kind of had a general idea. So that was helpful.
That's great. Anything from our clinicians about what you think helps make someone's treatment successful?
Well, I think one thing that we haven't had a chance to mention yet is it's a team effort, and we're fortunate to have an extraordinary group of nurses and other attendants in the unit where ketamine is administered. They do a detailed interview, and they really find out how someone is doing. They have a deeper understanding of the person than many of the physicians involved, and they're there more consistently. So, and plus, right now we often have one-to-one nursing care for our patients who get ketamine. That is an incredible luxury. It's an incredible safety thing, but it's an incredible thing from a humane perspective that, someone is there for the journey. And it's a large group of nurses who do this. And, it's Team Ketamine. And I think it's more valuable than the Michigan football team.
I think our patients would agree. So we're coming to the end of our time together. Before we do close, anything else from any of you on closing thoughts or remarks, things we didn't touch on, things you really want to drive home? Maybe Dr. Geller, we haven't heard from you in a while. Anything you'd like to add? And don't forget to unmute. There you go.
Yeah. I think I'm just really grateful for the community's interest, for the panelists, the lived experience panelists for sharing. It was just so special to hear your journey. We get it from our perspective, and it's so powerful to hear from you. Yeah, and to the folks that made this happen.
Dr. Basilio?
Yeah, I would just like to echo that and thank you so much for everyone who joined today. I think this is a really exciting treatment, and we want to put it out there in a light that's going to be, emphasizing how good of a treatment it can be, but also ensuring that people are getting it in a safe way that's going to be effective. And we just really appreciate the support from the community, and thank you so much to our patient panelists for being vulnerable and open.
Linda or Michelle, any closing thoughts?
I think I'd just like to again say thank you to the whole team at U of M, because it's, Linda spoke that she's a nurse, I'm a teacher. So in those professions, you give a lot of your life and love and energy to those people that that you're helping. And I know that these doctors and researchers have put in amazing amounts of time and hours, and I know they're very busy. And even just the time that Dr. Parikh has taken, or his physician's assistant has taken, or Dr. Maxner has taken to have those conversations with me on rough days when I come in for treatment, that have really helped me along the way. And having that team behind you and knowing that they are some of the most brilliant minds in the country and possibly in the world is just a very it's a great feeling, and I'm very fortunate to be a part of it. So thank you.
Thank you. And Linda?
Just thanks for the opportunity to be here and to share.
Great. Dr. Parikh, you get the last word.
Well, I echo everyone's thanks, and particularly thanks to Linda and Michelle. But I did want to say one more thing, and both Linda and Michelle emphasized that it's a journey. Ketamine, this is an incredibly exciting time to be in psychiatry because we have so many new approaches and new treatments. There are new medicines, there are new forms of brain stimulation, such as transcranial magnetic stimulation, new ways of doing that, TMS. And there are other things that are around the corner. We briefly mentioned, magic mushrooms or psilocybin and things like that. The important thing to remember when you think about a journey, there's never going to be one thing that fits everybody. So ketamine will be good for some people, maybe a lot of people, but so will TMS, or, there are new accelerated forms of even psychotherapy. So there'll be different ways to benefit. And there are digital tools, apps and websites and different ways of learning and organizing your life that can also be helpful in depression. So don't be discouraged by the idea that there's a journey. Instead, think of it, you're a kid in a candy store and you get to look at all the different candies and find the candy that you like. There will be a treatment. If you're struggling, or if you have a family member struggling with depression, there are lots of options. Don't give up hope.
What a great note to end on. Thank you all. Thanks to everyone who submitted questions. Thanks to everyone who registered. Those who did register in advance, you'll get an email with the link to watch. We're going to have this video up on YouTube. It will be widely available. We really appreciate everyone's time, and thank you again. Good night.